tool for quality improvement. Thank you.
Thank you, Dr. Jackson. Good afternoon to everybody. My presentation will start from where Carlo finished, and I essentially talk about how indicators are just a beginning towards the achievement of quality and safety in day surgery and more in general in health services. Do I press here? Okay. Sorry. Okay. So I talk about, what do I press? Okay. Okay. So my presentation will cover briefly a short list of the surgery indicators that we develop through the project, and I show you, as I said, that this is just the beginning towards improvement of quality and safety, and then I talk about accountability and improvement, and I will concentrate my attention on patient safety and in particular on the concept of active versus latent errors, and I will differentiate the blame and shame approach and with the just culture approach. And finally, I will talk briefly about a strategy to promote improvement in safety in healthcare services, including the surgery, which is called the 7 Pillars, which was designed by a university in Chicago. So this slide was already shown by Carlo. We, within the project of the surgery project, we classify the indicators in 9 categories, and we developed 4 lists of essential and ideal indicators for national and day surgery unit level. This is one of this list. It's the same that Carlo showed a few minutes ago. It's the essential set of day surgery indicators for the national and regional level, classified again by categories, which is input, access, output, outcome, safety, and cost and productivity. And what can we do with these indicators? There are many goals that we can achieve. One of the most important is accountability. And accountability entails a few measures publicly disclosed. So I don't want to keep these measures inside my hospital or my day surgery unit. I have to disclose it to everybody, the public and the society, policymakers, managers. One of the problems with this goal is that essentially accountability implies no involvement of providers in developing the measures and in carrying out the measures. So accountability allows a comparison in a transparent way of performance of different systems or structures across countries or within regions. And the aim is to reassure citizens and policymakers that services have it is an acceptable or a good level of performance. And also another goal is to promote change if necessary, and to guide decisions regarding allocation of resources and organization of health services, which is evidence-based, which means based on facts, not based on opinions or impressions. This is an example from the country where I come from, Italy, of the huge variation in cesarean section across all the hospitals in Italy. On the horizontal axis, you find the volume from up to 7,000 cesarean sections to the right-hand side, and on the vertical, you find simply the proportion from 0 to 1. So as you can see, you have hospitals where maybe 5% of the deliveries are cesarean sections, and others where 90% or even more deliveries are cesarean section. This is very important. This is an essential step towards improvement. We have a serious problem. There is a huge dispersion around the mean, and this is not acceptable. We don't have different socioeconomic conditions or clinical conditions which can justify this variation. So again, this is an example of an information which is essential for accountability, for an accountability goal. But then improvement, we can use indicators for improvement, but indicators are not enough. In order to improve health services, we need several confidential measures. Confidential meaning we keep them inside our unit or our hospital or our system. And these measures are mainly focused on processes. And this time we want to fully involve providers. And these measures, which include indicators, allow us to better comprehend the extent and nature of problematic processes from the perspectives of both providers and professionals. These measures also motivate change and allow us to monitor progress towards improvement. So I want to talk about, as I said at the beginning, especially about the patient safety improvement. Again, there is a huge variation around the world of how different systems have confronted this topic here. A definition of patient safety from the National Quality Forum from the US is the avoidance and prevention of patient safety injuries, harm, resulting from the processes of healthcare delivery, which means that this harm does not derive from normal evolution of the disease or the trauma. It's a consequence of what we do to the patients. And one of the most important, one of the first considerations we must keep in mind when we think and act on patient safety is that our systems are too complex to expect even extraordinary professionals to perform perfectly 100% of the time. In other words, we are not able to be 100% reliable because we faced too much complexity, and also because of our intrinsic weaknesses, which I will talk about in 1 second. So we as leaders, as professionals, have a responsibility to put in place systems to support safe practices. Okay, this is a little creature with a lot of complexity going around. And to be more specific about the concept of reliability, here we have a simple table showing, I'm sorry, I don't have a laser, so I cannot point, but on the left-hand side, you find the number of steps in a process from 1, or just 1 step, down to 100. An injection of a medication to a patient takes around 40 steps. And then on the vertical, on the horizontal, you find the probability of success of each step. So if you have, of course, if you have 1 step and then 0.95 probability of success, that's the probability of success of that step. Then if you add the steps, if you have 0.95 reliability, and then you have 100 steps in a process, you end up with less than 1% of the processes performing perfectly. And even if you go into the extreme right, even if you have a process which is reliable 9,999 times out of 10,000, with 100 steps in a process, you end up to be reliable only 99% of the times. Okay, so this is a simple way to show how problematic is to ensure reliability in the delivery of services, or complex services. So Ben was just a 7-year-old child, and Ben went for a day surgery, procedure, elective ear surgery. The surgeon injected lidocaine around a year, and Ben went into a cardiac arrest and died. And Ben died just because instead of lidocaine, the surgeon injected epi, which was poured into an unmarked sterile container. So even in a rather simple procedure, danger is always present. So one of the key ideas around patient safety is that this idea comes from a great researcher from the UK, James Reason, a psychologist who was the first to write systematically about human error. And he wrote in a famous book, which is called Human Error, 20 years ago, that rather than being the main instigators of an accident, operators, professionals, tend to be the inheritors of system defects. Their role, the role of providers, is that of adding the final garnish to a lethal brew that has been long in the cooking. Okay, so the idea that the problems lie mainly where management is, where the so-called blunt end. So this is a simple way to imagine an organization. We have the sharp end, where providers meet customers, meet patients, and where the active errors are, and we have management with the blunt end where latent errors are. So errors in the blunt end are there by design or by lack of design, because most of our processes are not really designed on purpose. In a medical school, we don't learn how to design processes. We don't learn how to design systems. We don't even think in terms of system processes. We inherit what other people have done, what our predecessors have done, and things have always been done in the same way, and we are not educated to think critically about the processes that we face. So we have active and latent errors, and the limitations we have as human beings in terms of memory, in terms of stress and fatigue, of sleep deprivation, and also in terms of distraction and interruption. We work in an environment, healthcare, which is characterized by continuous interruptions. And also, we as human beings have a problem with multitasking. So I read that somebody says that a human being can just walk and chew a gum. That's the maximum multitasking that a human being can do. But even so, all these human limitations make sure that providers make mistakes. And this is, down here, is the reason model, where you have, in the left you have the latent errors, which belong to the institution, to the culture, to the organization, the profession, the team, and then to the extreme right you have the active error. And again, if we look at errors only through the eyes of the provider, we miss the big picture, and we will not be able to modify our performance in terms of safety and quality. Okay, so the latent errors are where our attention should be focused, and they often are unrecognized. We become accustomed. We tend to ignore latent errors, and we learn to work around them. Nurses, physicians think that something which somebody else, maybe from outside, would consider like a normalization of deviance. Most of insiders would consider something normal. So another key concept is that we don't only tend to err, we tend to drift as human beings, and also as groups, as organizations, and as whole societies. If we are not aware, if we are not careful, if we don't have strong leaders, credible leaders, we tend to drift. And this means that small changes become the norm. Additional deviations become acceptable, and signals that something is wrong are overlooked or misinterpreted. And so what is the traditional response to this state of affairs is blaming and shaming. And this approach has three different options. The first is we accept that human error is inevitable. We keep our fingers crossed, and we tell the provider to be more careful next time. The second option is we hold the provider responsible, and we discipline him or her, and we can even fire. So we teach a lesson to everybody else. But the third option is we give him the benefit of the doubt and retrain him. We can be almost certain that the training will fail because the fundamental circumstances, the latent errors, have not been changed. So the alternative to the blame and shame culture is the just culture. The just culture was conceptualized for healthcare by an engineer whose name is David Marks from the US. And he makes a clear distinction between among three different kinds of error. Human errors, which are slips and lapses and mistakes, which come from our deficiencies in memory and concentration. And the great majority of errors in medicine are human errors. And the proper response to this kind of errors are to manage through redesign of processes and training, essentially consoling. And the second category of errors within this perspective of just culture is at-risk behavior, which again goes to normalization of deviance. a choice risk not recognized or believed justified by individuals and groups. And here we need to increase situational awareness that something is going in a different direction, is already in an area, performance has already entered an area of which is unsafe and which should be changed. And then we create incentives for healthy behaviors, and we remove incentives for at-risk behavior. And essentially, we coach. And the third category is the reckless behavior. It's like somebody driving 100 kilometers per hour in front of this hotel. That's a clear violation of basic safety rules, and this behavior, which is conscious disregard of unreasonable risk, should be punished. Okay? Okay, so the just culture is crucial because it differentiates between system issues, but also keeps individuals accountable for violations of safety policies. You know, I mean, not cleaning hands in between patient visits, or refusing a timeout before a surgical procedure are clearly reckless behavior and should be recognized as such and punished. And to deal with this kind of situation, it's a strong leadership, a courageous leadership, a leadership which is ready to burn some feathers is absolutely essential. And one of the effects of leadership on and also culture on the unit level comes from this slide, which is, if I remember well, from Johns Hopkins University, and it shows how the teamwork climate across these 29 clinical areas within the same organization is quite different. To the question, how do you consider do you consider the teamwork climate in the unit where you work as good? You have to the left-hand side somebody answering, 5% of the providers, of the professionals answering yes, and then you have in other units 98% of providers responding yes. So, so in healthcare, we have to pay attention at the culture at the unit level, more than the culture at the hospital or health system level. And we know perfectly this. I mean, by our experience, we know perfectly that how we experience some units as something which we wanted to be part of, and some other units we wanted to flee and leave as soon as possible. So, sorry. So this is a disaster which happened in Italy, I think 1 year ago. And it's a cruise which hit a rock in central Italy. And it went down and it killed 30 people. And this is the opinion expressed by a captain of cruise ships, who says that experience can be our biggest enemy. As we increasingly become proficient at a task, we often stop paying as much attention. And so there is a danger of becoming comfortable. This is a danger which involves not only captains of ships, but also medical professional clinicians. I mean, we tend to become, sorry, I can't find the word in English, but again, comfortable with what we have been doing for years. And this is dangerous, because we This means that we are not able to be aware of changing circumstances, of new circumstances just happening in front of us. And still another comment from this Concordia tragedy comes from another captain, and he says that it was clear to him that the apparent total failure of the vessel bridge team to support the captain decision-making. And based on his experience, the most likely barrier to bridge team support is the ego, arrogance, and intimidation of the captain and his relationships with subordinate officers. It's not a company or nationality issue, it's usually a personal issue. Okay? This is also a lesson which is relevant to healthcare. And it links to the idea that culture is local because leaders are very different. Within the same organization, leaders of operational units have very different personalities, very different leadership capabilities. So, what is the solution of these problems we have, and not only in healthcare, but in complex organizations? By the way, there is no other human activity which is as complex as healthcare. Some people have measured the number of steps that are needed to deliver healthcare, and the number of steps and the complexity of the steps are uncomparable with other human activities. Starting with piloting an airplane or piloting a ship. So we should be aware of this. And but I think most medical schools don't tell us that we are going to face the most difficult job on earth. And so one of the solutions to this, sorry, I don't want to keep, should I stop in 5 minutes? 5? Okay. 2? 1 minute? 1 minute, okay. Okay, so I jump to the end of this presentation. Maybe I show this slide, contrasting the old approach to the new approach. The old approach would tell us that safety is an individual responsibility, whereas the new approach is a system property. We must design safety and quality inside the system. Information is a record or is an indicator, whereas the new approach would say that information is not enough. We need to share knowledge and free information flow. The old approach is secretive. The new one is transparent. It's a glasnost. Yes, we remember that. And in the old approach, we react to adverse events, whereas we want to anticipate adverse events. And in the old approach, we justify professional autonomy. We justify professional autonomy and the variation linked to professional autonomy, whereas in the new approach, we want evidence-based decision-making with respect of patients' expectations and desires. Okay, so in conclusion, indicators are important especially for accountability, but are not enough for improvement. Improvement implies a better understanding of managerial concepts and deeper analysis of local context and processes. We humans, although we are extraordinary in terms of intelligence and capabilities, skills, courage, but still we make mistakes. Harm is mainly the result of latent errors, but we should punish violators. We need strategies which focus on systems and culture rather than people. We don't want Captain Schettino leading our organizations. In progress, so progress depends heavily on senior level, visible and consistent commitment, and we should always, no exception, respect the wisdom of the frontline workers. And I thank you for your attention. Sorry I took too long.
Thank you very much, Roberto.